everybody. I am Dr. Rami Kaldas at the Kaldas Center. I have been around for about 21 years in Wisconsin trying to make people's lives better. And we want to hear from you tonight. What has been causing you great anguish and pain? And I want to hear all about your challenges tonight, having to do with fertility, pain, endometriosis, or very inconvenient things like incontinence, or even if you were born with an abnormality that has hindered you from being able to get pregnant. So we are here to arm you with education, to be your own best advocate. As always, please consult your doctor before you make any decisions or take action, because we are here simply to share information with you and make you ask questions that will inform you, and we are here to help inform you so you can get the best results wherever you are. Obviously, if you feel like you want to make a consultation with us at the Kaldas Center, pick up the phone, talk with one of our nurses, and you can decide if you want to make the journey to the Kaldas Center from in-state or out of state. You can call 920-886-2299 during normal business hours, or go to kaldascenter.com/contact. So let's get to the questions that some people have proposed already. So the first one comes from Jennifer. Are fibroids genetic, and how are they treated? There is a genetic component to fibroids. Fibroids, also known as leiomyoma uteri. If your mom had them or your sisters have them, you're way more likely to have them also. But that is not necessarily the case. If your mother had them, you don't necessarily have to have them, and vice versa. As far as the treatment for fibroids, each fibroid begins with a single cell, and then it proliferates. So it's like a tumor, but it's not a cancer, though a very small percentage can become cancerous, about 1 in 400 or so. But let's assume that is not the case. Fibroids happen about in 1/3 of women after the age of 35, and the way that they're treated, they can be kept in check with medications, but the challenge with fibroids is that because they're actual physical entities, they are like balls in the wall of the uterus. Some people in parts of the country, that's the reason they call them fireballs and so on and so on, because they can cause a lot of bleeding and pain and cramping. But they can be treated sometimes with medical therapy, but usually it has to be a procedural intervention. For example, if there's just one big fibroid near the surface of the uterus, then it can be treated by cutting off the blood supply by something called uterine artery embolization. Cut the blood supply off and it shrivels up. Or the way I treat most of the fibroids here at the Kaldas Center, since so frequently people just don't want a hysterectomy, and a lot of times people are wanting to get pregnant. So I treat them with the hysteroscope most of the time. That's where we literally shave them out from the inside and preserve the person's fertility and her uterus. Frequently you can treat them laparoscopically. You can literally remove them from the uterus and put them in a bag, and then remove them through a small hole in the abdominal wall laparoscopically. But if the fibroids are really, really big, then you can either try radiofrequency ablation, where you really actually shrivel up the fibroids with directed radiofrequency, or you can have an open surgery where you remove them. The most fibroids I've ever taken out on someone are 50, and that person, I'm glad to say, went on to have 3 children after that. So don't be fooled, please. If someone says you need a hysterectomy for fibroids and you don't want one, please get a second opinion, ask your doctor, ask another doctor, call the Kaldas Center. We'll tell it to you straight. The next question comes from Noel. After 5 failed intrauterine inseminations, I find out that when my doctor did blood work, they only tested my thyroid and pituitary gland. His HSG was normal, hysterosalpingogram, so shouldn't I be tested for other things like hormones and progesterone? What would you test? Great question, Noel, because we see new fertility patients every day at the Kaldas Center. The average time they've been trying to get pregnant, I bet you, is more than 3 years. And they've usually gone through several providers. So it can get to be very frustrating. Fertility therapy can be an emotional roller coaster, especially if a shotgun approach is taken. So you have to have method to the madness. And so I would recommend not only testing the TSH, or thyroid stimulating hormone, but actual thyroid hormones, the T3 and the T4, especially if the TSH was on the high or low end of normal. Additionally, you want to be sure that you rule out the possibility of polycystic ovaries or polycystic ovary syndrome. And so you test for that by checking luteinizing hormone and FSH levels, follicle stimulating hormone levels, and see the ratio between them. And then also get an insulin level that can suggest polycystic ovaries even if you don't have the syndrome. Additionally, an antimullerian hormone level will be higher if you have bad polycystic ovaries and quite low if you have poor ovarian reserve. So an antimullerian hormone, an AMH level, is important too, in addition to the ones you mentioned. I don't usually get progesterone levels because we are going to support the lining regardless. Progesterone levels can be hit and miss, and they're very individualized. It used to be we used to get a biopsy from the uterus to see if there's enough progesterone, but that's painful and expensive. Additionally, of course, you want to make sure that your partner is tested. 40% of the time, it's the male factor. Get that semen analysis. You don't want to be pumped full of a bunch of fertility drugs for 6 months or a year, and then get the semen analysis and find out it had not much to do with you in the first place. So those are the tests that I would recommend, okay? And an anonymous viewer writes in, I am only 34 years old. Is incontinence normal at my age? Depends on what normal is, because if someone has had a lot of children, especially delivered through the birth canal, you can have incontinence. There are different types of incontinence, and it needs to be determined which one it is. Sometimes it's really easy to determine where the incontinence of urine is coming from. Most of the time it's by pushing babies out through the vagina though. And that results in the connective tissues, the fascia, that is in the walls of the vagina being stretched and even pulled off of the bone. And so you don't have the support that you had before having children. There is a genetic component to it. If you have a collagen that's easy to stretch out, or connective tissue. So then what ends up happening is you have a urethra that is really easy to move. So when you cough or sneeze, that top of the urethra, where the urine comes out, rotates down, and there's more pressure in the bladder, then you leak. And so it can be quote-unquote normal, but it sure isn't normal for someone who wants to live a quality life. And it sure is possible to treat with, biofeedback and Kegel exercises. Ask your doctor about a physical therapy consultation, or products that are on the market that can be placed in the vagina to support the urethrovesical junction, or pessarase, or surgical interventions with or without mesh. There are slings with mesh, but there are other surgical interventions that do not require mesh that have over 90% success rates, and those are the interventions like the Birch cystourethropexy that I employ a lot for my younger patients. Since they have equal efficacy, they don't involve mesh. And so that's how you would look at incontinence in a young woman. Oh, and then we have another question from Lisa. Is there a good way to tell the difference between period pain and endometriosis? That's a great question, Lisa. Well, killer periods are simply not normal. Whatever you heard from your grandmother about how it's normal to be curled up in a ball and want to cry like a baby for 3 days, it's wrong. Sorry, Grandma. So, if you have killer periods and you're gobbling up the ibuprofen in abundance, there's a good chance you have endometriosis, or a kind of endometriosis called adenomyosis right in the wall of the uterus. And imagine if you have endometriosis of the wall of the uterus. You bleed into the wall, you're like, your entire uterus is one angry bruise, and it hurts, and it's an unhappy time. And then you get all kinds of crazy gushing blood, frequently but not all the time. And then with endometriosis, you frequently will have diarrhea when you're having your period. You can have rectal spasm, pain with your bowel movements, or pain with intercourse a few days before you get your period that may last until the following morning. That is all associated with endometriosis. There are other reasons, like uterine anomalies that people are born with, like a uterine septum, that can cause really painful periods. And of course, that's something that we do at the Kaldas Center. We take care of a lot of abnormalities that people are born with, so they don't have so much pain, but yet we can preserve their fertility and enhance their fertility through these interventions by getting rid of the abnormalities that they were born with. Hey, let me mention again that if some of this sounds like way far out, and I ask you to go ahead and talk with your doctor about it, and if you want to, give our nurses a call and see if you think you'd like to maybe visit the Kaldas Center, invest in the drive or the flight to come over, and that number is 920-886-2299 or kaldascenter.com during normal office hours. So, there's another question from Rachel. Tell me more about diastasis recti after having babies and C-sections. So diastasis recti, that will happen sometimes with just singletons, but certainly if you have multiple gestations. And what's going on there is, in the abdominal wall, before having babies, their muscles are together, and right above the muscles is the rectus fascia. Once again, I use that word fascia, the connective tissue in the abdominal wall above the muscles. And so what happens is the two long muscles up and down the sides of the abdomen will actually separate, and the fascia gets stretched out. And it literally stays stretched out after you have the baby or babies. And so when you try to do a sit-up, there's this big ridge that just bulges out right in the middle of your abdomen, up and down the length of your abdomen, because your actual muscles are separating to the sides because they have been stretched apart during the pregnancy. Whether you have a C-section or not should not affect whether you have that diastasis recti. It's not a good idea to correct that right after a C-section either, or right during a C-section, because your uterus is still quite substantial after having the baby. And therefore, most people who correct that want you to not be pregnant for at least 8 weeks or so they know what normal is for you when you're not pregnant, and then they can sew those muscles back together and take the slack out of the stretched out fascia. So you can get back to, teaching Pilates or yoga and having, those rock hard, abs. And then there's a question from Jane tonight. Is it possible to have a natural birth after a cesarean section? Do you recommend it? Oh, that's something you should talk to your doc about. Of course it's possible to have a natural birth after a cesarean section. You've just got to have precautions taken, because there's about a 1% risk of a uterine rupture during labor after having a previous cesarean section where they went across the bottom of the uterus to deliver the baby. If they went up and down on the uterus, though, it's a little more risky and not a great idea to have this a vaginal birth, a natural birth, because then they've gone through the really thick muscular part of the uterine wall, and the chances of a rupture are much higher than if they did a low transverse C-section. Do I recommend it? I recommend it for people who want to do it. Absolutely, I support them in that. As long as the criteria are met to make it a safe thing, I do suggest that you keep an open mind though, because of the 1% risk of uterine rupture, you do need to at least have an IV in place. It doesn't need to be connected to anything, and to have continuous monitoring when you're in active labor, because once the uterus ruptures, the doctor needs to know right away. Most places who do, trials of labor after a prior C-section require that a doctor who knows how to do a C-section be immediately available, like in the hospital. So you want to know right away if the uterus ruptures, because when it does, the chance of a bad outcome, like baby dying or cerebral palsy or a hysterectomy happening, is about 50%. So you want to catch it early and get that baby out fast. The standard of care, I believe, is 30 minutes to get the baby out. Well, you try holding your breath for 30 minutes. Not my standard. I like it more like 10 minutes, and that's the way you stay out of trouble. But things move really fast then, and it's not for everyone if they have easy or high anxiety. So, Laura has a two-part question for us. Let's go ahead up and ask the first one. What are the chances of being able to get pregnant with fertility treatments if you have endometriosis, Pcos, and adenomyosis? Wow, Laura, sounds like my average patient. I think they're really good. I think most likely that person is 95% likely to get pregnant if they come to the Kaldas Center, but it's just a matter of what is it going to take, and it needs to be a directed therapy. So a lot of the times, most of the time, I can tell on examination when someone has endometriosis. Look at the family history, look at the examination and the personal history, and you can pretty much tell 90 to 95% of the time if it's there. And then if it's there, it's a good idea to treat it because it does reduce fertility by 50%. But the treatment must be excisional. Burning it does not work. It doesn't work for pain, it doesn't work for fertility. So you have to take it out, and we do that with the carbon dioxide laser and a brief day surgery for our patients at the Kaldas Center. That's the way to do it. But most certainly, I have hundreds of patients who, if not thousands, who have all three of those things, and they thankfully overwhelmingly have all become pregnant and continue to do so. So don't give up. So do any of the above conditions cause you to be high risk in pregnancy or less likely to be able to carry a healthy pregnancy? Well, that's a great question. You are a little bit higher risk because of the comorbidities with polycystic ovary syndrome, and there is a higher risk of miscarriage to the tune of 4-fold higher risk when you have polycystic ovary syndrome in the first trimester. That's why it's recommended to stay on the metformin until 10 weeks gestation to reduce that risk to normality. So, great idea to do that, totally safe, very long history with metformin and keeping pregnancies safe. The other thing is with adenomyosis. Traditionally, it has not been recognized to cause issues of miscarriage or cause issues of getting pregnant. More recently, in the last 3 years, there are articles that are reporting a higher incidence of miscarriage associated with adenomyosis. With if you have an adenomyotic uterus, in my personal experience, when you deliver the baby, you are more likely to bleed heavily. But just be prepared. For your doctor or midwife, you just have to have someone who is always looking around the corner and not doing stuff they don't need to do, but just being prepared for the possibilities that come, but not just doing stuff, for the sake of it. Hey, and we have a question from Tara tonight. What is a birth control that will help keep under control endometriosis and is safe to use while breastfeeding? Do all these need to be progesterone based? Great question, Tara. All right, first of all, breastfeeding is 98% contraceptive for the first 6 months. So if 98% is good enough for you for the first 6 months, you don't need to do anything for your endometriosis with the pill, because the breastfeeding is also keeping your endometriosis in check. Once someone excises endometriosis, the way to keep it from coming back is to avoid periods. Avoid your period. And it's perfectly safe to be on a continuous contraceptive pill. And there are good studies that say nowadays the low-dose combination contraceptive pills with both estrogen and progesterone are compatible with breastfeeding. It doesn't have to be progesterone only. Okay? Additionally, you can always consider an intrauterine device, either with hormones or without hormones, but the one with progesterone in it, the Mirena or the Skyla, will help prevent recurrence of endometriosis because they get rid of your period most of the time. So if you don't have periods, you don't have backwards flow of endometrium, which is what causes, endometriosis. Not the main cause of endometriosis, is the vehicle by which endometriosis happens. Because 100% of women, unless they've had their tubes tied, have backwards flow of period blood. But it's about 10 to 15% that don't clear it out with their immune system. Okay? So let's review. Endometriosis will be kept in check by breastfeeding, because most likely you won't be having a period. And breastfeeding is contraceptive to the tune of 98% for the first 6 months. And then you need to be on something to just prevent the period from happening. And that will, keep you, longer, free of pain, and not needing another surgery to get rid of endometriosis. Thank you for that great question. Lisa asks, I have endometriosis and polycystic ovaries, and I'm struggling with my weight. What do you recommend for successful, healthy weight loss? I feel that I have tried every diet out there. Well, for someone with polycystic ovary syndrome, as you know, Lisa, you have a glycemic index issue. You must try to minimize carbohydrates to an extreme. And I would recommend a very low carbohydrate diet, especially in the beginning, even considering eliminating some fruits, and simply trying to stick with a more protein-based diet. You want to be aware that if you eat a carbohydrate, if you have the munchies, and you go off and have a few crackers, you will be hungrier in an hour than if you had never eaten the crackers at all, because it will spike your insulin right up, and that will make you hungrier. The insulin will cause storage of fat and reduction in utilization of fat for energy, so it's just a bad situation all around. It's tough though. Portion size, minimization of carbohydrates, it's a radical shift, and it's not what everyone around you is doing. Therefore, when you go out to the pub, you can't eat like what everyone else is eating. And it's no fun sometimes. So you gotta plan it. It's worth it. And when you drop the weight, as far as with polycystic ovary syndrome, then you will actually be far more fertile. As far as an endometriosis diet, I invite you to go to KaldasCenter.com, because we do have diets that are recommended for people with endometriosis to minimize inflammation. Hey, and a question from Chichi, I think. What a great name. I love that name. I have endometriosis and adenomyosis. I've had about 6 surgeries. They have me on Nexplanon and Nora birth control, and pain is still there. They asked if I wanted a hysterectomy when I was 21, but I'm not ready for that. I'm 25 now. What are some more options for me? Holy cow. All right, first of all, you need to be sure that you're reading your pathology reports from the prior 6 surgeries. Did someone go in there and just burn around? They didn't help you, sadly. So you ask to see the pathology report and see that it was excised. Read your operative report. Did they write in there things like the endometriosis was too close to the bowel or the ureters, therefore we didn't touch it because it was too dangerous? If that's the case, you need to talk to your doctor and find a doctor who is experienced and comfortable in doing that with a near 0 or 0 complication rate. Obviously, all surgery has a risk of complication, but there are a handful of surgeons out there that can do this for you in this great land of ours, and they will take care of you. Then, as far as the Nexplanon goes, that's all fine and good, but I might, if it's not getting rid of your period entirely, then maybe it's a good idea to look at a Mirena or a Skyla IUD, if you haven't tried that already. Additionally, it's important to think about the scarring endometriosis causes, and the physical therapy may be required. Because even when you remove the endometriosis repeatedly like that with multiple surgeries, you can have scarring and you can have nerves that are causing pain without recurrence of the disease. And therefore you may need to consider medications like Neurontin or amitriptyline that block the transmission of pain in the nerve fibers once the endometriosis is treated. If the endometriosis is central only, that doesn't go out to the sides, a presacral neurectomy has been shown to work 75% of the time. However, results are not forever for a lot of people. The pain may start coming back after about a year, and only do that with someone who really knows what they're doing, because that entails taking nerves out that are coming out from under the aorta, and you can get into an unfortunate situation unless the surgeon knows exactly what they're doing laparoscopically. Thanks for the question. Hey, and from Jamie, are there warning signs of polycystic ovary syndrome? Well, first let's talk about the continuum between polycystic ovaries and polycystic ovary syndrome. It really stumps a lot of people. In Europe, it's entirely a diagnosis of ultrasonic appearance. Ultrasound. The ovaries look polycystic. They've got polycystic ovaries. In the US, we make more a big deal of the actual syndrome, which is the minority of people with polycystic ovaries. Most of my patients with polycystic ovaries are quite thin, but they're never having a period. All their labs are otherwise normal, and they have very polycystic ovaries. So with as far as warning signs of polycystic ovary, you can have any body habitus and have polycystic ovaries. To actually have the syndrome, though, usually people are a little overweight or very overweight, so much so that they actually have like stretch marks on their belly, and on the back of the neck there is a darker skin with wrinkles called acanthosis nigricans that is pretty much pathognomonic. It pretty much almost only happens with polycystic ovary syndrome. If you've got that on the back of your neck, then most likely you've got it, and the testing should be done with the ultrasound and the lab work to confirm it. I'll tell you, I can't tell you the number of patients I've impressed when they walk in and they're wondering why their periods are all over the board and they're not getting pregnant, and I look at the back of their neck and instantly I am a genius in their minds, because they've seen a bunch of other people who had never looked at the back of their neck and said to them, oh, you have polycystic ovary syndrome. That's why you have this all going on. So check that out with a mirror tonight and see if you have polycystic ovary syndrome. Hey, looks like it's time to wrap things up. I'm sorry that we didn't get to your question tonight. I've been just talking, and this is just like I talk every day to my patients. That time went by really fast. So if you have any other questions, we would be delighted to hear from you. We've got amazing nurses at the Kaldas Center who are happy to take your call and very forthrightly recommend to you whether we think you need to come in or not, or whether you can try to get done what you need to get done where you are. And so, but I'm sorry that we didn't get to your question. If we didn't get to your question, thanks for joining us tonight. Thanks for letting me chat with you. All I was doing what I do every day, and we want to make your life better. That's what makes us tick. You have a great evening.